delaying, let me introduce the panelists for this session. We are having Dr. Deepika PC ma'am and Dr. Sunil Tejasvi sir as our panelists. Dr. Deepika PC ma'am completed her BDS from GDC Bangalore and MDS from Bapuji Dental College, Davangere. She is working as a professor from 2012 till date at JSS Dental College and Hospital, and currently she is the professor and HOD of the Department of Periodontology in the same. She has many national and international publications on her credit, and her area of interest is periodontal regeneration. We are privileged to have you here, ma'am. Talking about Dr. Sunil Tejasvi sir, he pursued his Bachelor of Dental Surgery from GDC Bangalore and MDS from KBG Dental College, Sulia. Sir has an experience of 18 years in teaching and has many publications.
Dr. Anirudh, extremely sorry for the late login. We got a little delayed, have we?
No problem. No problem.
No?
No problem.
He has many publications on his name. Sir has contributed a chapter on dental health in diabetic patients in the textbook of Diabetes, the Invisible Enemy. He has special interest in root canal irrigants and has applied for the patency. We are glad to have you with us, sir. I now request Dr. Anita ma'am to introduce our speaker for this session, Dr. Aniruddha Acharya, sir. Over to you, ma'am. Dr. Aniruddha Acharya, sir, is a faculty in the Department of Preventive and Restorative Dentistry, College of Dental Medicine, University of Sharjah, UAE. His educational qualification includes BDS, MDS in periodontics, PhD, and MFDS from the Glasgow, UK. He has a range of publications in peer-reviewed international journals. He is reviewer to several international dental journals and was section editor of Journal of Interdisciplinary Dentistry. He has held a variety of academic and administrative posts in his terms and has been master trainer for dental faculty. He was organizing secretary and convener of national conferences and symposia. He is life member of several dental societies, and he has been invited as speaker and has numerous national and international presentations on his credit. Over to you, Aniruddha, sir.
Thank you, Shipra, for the kind words. Am I audible?
Yes, sir.
I think we can start, Dr. Shipra.
Is the screen visible? Are the slides visible?
Yes, sir.
Yes, sir.
You're audible and visible. Yeah.
Fine, fine. Thank you so much. Thank you so much. This particular presentation at JSS is actually quite special because I'm amongst my JSS family. Having been there about 15 years ago, I have to start with Dr. Ravindra sir, Dr. Deepika, Dr. Sheila, Dr. Pratibha, Dr. Anita, Dr. Avinash, Dr. Vidya, all my JSS Perio network. So it's really a pleasure being here and making this presentation. And one more thing why it's special is for the reason that since the cat is out of the bag now, this is probably the first time my father and myself have been on the same academic platform. So that makes it quite special too. So thank you for having me, especially the organizers. And without much ado, I have been given the task of presenting the oral immunological aspects of diabetes. Of course, I will be focusing on the periodontal aspects majorly. Now, diabetes has already been defined by Dr. Prasanna Kumar earlier, so I'll not be going into that. But however, I would like at the outset bring about the similarity between diabetes and periodontitis. Both are multifactorial diseases having environmental factors, lifestyle and behavioral factors, as well as genetic factors playing an important role. And please note that the term multifactorial is relevant to killer diseases. And from the point of view of the tagline of this particular webinar series, Killing the Killer, caught my attention, and my compliments to the person or persons and the organizers who actually have coined it. For the simple reason that diabetes is a global killer. If you look at the data which has been provided to us by the WHO, it stands 7 on the all-time list of a global killer. And needless to say, periodontitis is a global killer of teeth. This is based upon the data we have from the global burden of disease which claims that at least 2 out of 5 individuals globally are afflicted with some sort of gum or periodontal disease. So this actually makes it very imperative that we recognize, especially from the point of view of the medical fraternity, that periodontitis and diabetes are interlinked. And if we go back to 1993, when Dr. Harold Lowe first coined the term, the sixth complication of diabetes, we have this particular phrase in the literature, peppered across decades. But at the same time, I would bring to your kind attention that in 2008, the American Diabetes Association actually defined periodontitis as a complication of diabetes. But moving on, in 2018, the ADA sort of provided the description as periodontitis is a comorbidity of diabetes. So we need to take this into consideration and move on with respect to we as dentists handling periodontitis and the medical fraternity who's handling diabetes. So periodontitis is a comorbidity of diabetes. Now, the basic premise on which this link or the two-way street mechanistic link which is connecting diabetes and periodontitis is based upon inflammation. And I shall open up with respect to diabetes as an inflammatory condition for the simple reason that there is a concept that inflammation links insulin resistance, obesity, as well as diabetes. The hyperglycemia and excessive food intake result in cellular oxidative stress and resultant inflammatory changes. And this has led us to believe that hyperglycemia is a pro-inflammatory state. And hyperglycemia also results in an increased circulating inflammatory mediator concentrations, especially with respect to impaired glucose tolerance, thus proposing a causal role for hyperglycemia in the immune activation of diabetes. And this is what is described as chronic low-grade inflammation, which can accentuate insulin resistance as well as progression of diabetes. Needless to say, periodontitis is an inflammatory condition, and we know because of the bacterial insult via the oral biofilm, we do have a dysbiosis taking place and the host response in the form of inflammation, resulting in a protracted, unresolved inflammatory process, which results in the destruction of the periodontal tissues. And the dysregulation of the innate and adaptive immune systems play important role in the etiology of periodontal disease. We know this. Now, this is the inflammatory bridge. It doesn't look as simple, but it is quite complex because the best studied pathway for comorbidity between diabetes and periodontitis is inflammation. And this is basically because both the conditions are strongly associated with overt inflammatory processes. Both are associated with systemic inflammatory burden, which affects distant organ homeostasis. And there is vast information regarding the impact of inflammation on both these conditions. Now, I want to introduce you to an overview of how diabetes or hyperglycemia will be affecting the periodontal tissues. By and large, we will be having the production of advanced glycation end products, which will be affecting the cellular function, including the defense cells as well as the fibroblasts. In addition to that, this will be bringing about an expression of pro-inflammatory cytokines, leading to the expression of matrix metalloproteinases, thus bringing about periodontal breakdown. But at the same time, you also have hyperglycemia, which will be affecting the periodontal microbiota, which results in dysbiosis, resulting in PRR expression, again leading to an intricate but complex periodontal breakdown. So this is basically an overview with respect to how hyperglycemia or diabetes will be affecting the periodontal tissues. I bring to you a particular term which has appeared in the literature since quite some time, what is referred to as systemic dumping. This was actually put forward by Prabhu et al. And the basic fundamental concept behind this is that periodontitis may metastasize as an inflammatory disease into the systemic circulation, thereby bringing about a upsurge in the pro-inflammatory mediators, which impacts the systemic inflammatory status, especially when the particular individual already has one, such as diabetes. And periodontitis may induce or perpetuate an elevated systemic chronic inflammatory state, resulting in increased insulin resistance and poor glycemic control. Now, such an interaction is not linear, but quite complex. Another term which I am bringing to you is local dumping. This is not in the literature. I have just introduced this particular term for this particular presentation so that we have an idea as to how diabetes as such will be having an influence on the periodontal condition. Now, diabetes increases inflammation in the periodontium, which may bring about changes in bacterial composition. Now, I've highlighted changes in bacterial composition for a particular reason. Now, a few years back, there was a joint workshop between the AAP and the EFP regarding the interaction between periodontal diseases as well as systemic diseases. I shall be alluding to this particular workshop pertaining to the immunological aspect slightly later, but just to give you a background, that particular workshop actually came up with the conclusion that in humans, there's not much of a change in the bacterial composition with respect to individuals having diabetes. But however, more recently, there have been some animal studies. For example, a particular study which was done in diabetic and non-diabetic mice. So what the researchers actually did was they actually translocated the oral microflora from the diabetic mice onto the non-diabetic mice, and they found quite an increase in the inflammatory response with respect to the non-diabetic mice having been exposed to the diabetic mice microflora. So from that point of view, we should still consider that there is going to be a sort of a change in the bacterial composition with respect to individuals having diabetes. So then again, this particular change in the microbial composition will be bringing about an increase in the defense cells and their functionality as well as expression of pro-inflammatory mediators. Now, this is how probably local dumping would be conceptualized. Now, you have diabetes, which results in an overexpression of reactive oxygen species, cytokines, advanced glycation end products, which result in an increased inflammation, thereby bringing about periodontal destruction. At the same time, you have enhanced apoptosis of matrix-producing cells. All this will result in prolonged resorption and impaired bone formation and net bone loss, which is a hallmark of progressive periodontal disease. Another phrase is what we refer to as cross-susceptibility. This cross-susceptibility is the interaction between two diseases or more existing in the same individual. So inflammatory mediators play a central role in the inflammatory association between periodontitis as well as diabetes. Periodontitis is sustained by a network of pro and anti-inflammatory mediators, and these may either have an antagonistic or a synergistic biological activity. At the same time, we also have to take into consideration, based upon what I already put forward to you, that diabetes is an inflammatory condition. Systemic changes in cytokines and other inflammatory mediator levels are central to pathogenesis in diabetes. There are enough and more articles for reference in the literature with respect to the cross-susceptibility, the role of inflammatory cytokines, how the research into cytokines have actually driven our understanding with respect to the pathogenesis of both these disease conditions. There have been individual markers which have been studied, and more recently, the studies are focusing on multiple markers being studied so as to bring about a more valid association between the pathogenesis as well as the cross-susceptibility between periodontitis as well as diabetes. But however, as I mentioned slightly earlier, I would be taking you to this particular workshop, which was in 2013. It took place in Segovia, Spain, under the auspices of both the European Federation of Periodontology as well as the American Academy of Periodontology. They focused on the interactions between systemic diseases as well as periodontitis. And I shall bring to you some of the questions they answered from a conclusive point of view pertaining to immunological aspects of diabetes and periodontitis. One of the first questions they actually answered was based upon this particular finding, that there is evidence that periodontitis in individuals without diabetes increases systemic levels of cytokines, meaning to say that even if a particular individual is systemically healthy and without diabetes, a presence of periodontitis itself, from the point of view of systemic dumping, can increase the systemic levels of cytokines, which from another point of view is increasing systemic inflammation. This is what led the particular workshop to answer some of the questions. One being, what is the role of cytokines and other mediators in the mechanistic association between diabetes and periodontitis? And their conclusion was that there is evidence from studies that there is a relationship between diabetes and periodontitis with respect to the role of certain specific cytokines. And they are basing this particular conclusion that the patients with periodontitis as well as diabetes, there is an elevated level of several cytokines from the point of view of the local source. And we know that from the oral cavity point of view as well as from the periodontal point of view, saliva and the gingival clavicular fluid will be the most important sources. So their conclusions are predicated on the fact that these particular cytokines are actually found in different levels as compared to normalcy in saliva as well as the gingival clavicular fluid. Another question was, what is the role of oxidative stress with respect to diabetes and periodontitis? And the conclusion is that hyperglycemia enhances oxidative stress, especially in the periodontal tissues, and studies have shown that periodontitis promotes measures of systemic oxidative stress. And we know that oxidative stress is quite pivotal in bringing about periodontal destruction. We'll look at it a little bit later on also. One more question. What is the role of AGEs, that is advanced glycation end products, in the association between diabetes as well as periodontitis? Diabetes basically drives the formation of advanced glycation end products, which either directly or indirectly promotes inflammation, including periodontitis. And studies have shown that the age-range interaction leads to an exaggerated inflammatory response and the periodontal tissue destruction, which is seen in diabetes. This brings us to the most important immunological aspects pertaining to periodontitis as well as diabetes. And we start off with cytokines. We know that cytokines are a diverse group of small proteins with a variety of functions, which includes regulation of the immune and inflammatory responses. Now, cytokines function in complex networks. This is the reason why I mentioned in the opening slide the network. Everything is network based with respect to trying to at least figure out a certain amount of explanation regarding the sustained inflammatory burden in individuals who have got both diabetes as well as periodontitis. So they basically work in complex networks, and cytokines can be both pro as well as anti-inflammatory. And another important aspect is that both diabetes and periodontitis show comparable cytokines in their profile. So together, diabetes and periodontitis can be considered as distressed immune responses in a susceptible host. This is very important. I'll just take you through a few of the important cytokines which are found to be having a commonality with respect to both diabetes as well as periodontitis. Of course, the most important and vastly studied cytokine is interleukin-1 beta. It is a pro-inflammatory cytokine. It induces the production of many other cytokines, as well as induction of prostaglandin E2. It induces production of chemokines, as well as the adhesion molecules in endothelial cells, and it stimulates the effector function of neutrophils as well as macrophages. So interleukin-1 beta has been one of the most studied cytokines, both from the point of view of periodontitis as well as its association with diabetes. One more is interleukin-4. This is a multifunctional cytokine, and it is basically promoting T helper type 2 cell differentiation. In addition to that, it regulates cell proliferation, apoptosis, as well as expression of numerous genes. And we know that numerous gene expression will be having a direct effect with respect to the inflammatory process. Interleukin-6 has got pro and anti-inflammatory effects. It's something like a joker with respect to the inflammatory state, especially when we have more than 2 inflammatory conditions existing as comorbidities. It is quite difficult and challenging. Even in the literature, you tend to find a lot of contradictory indicators with respect to what interleukin-6 exactly does. But however, at the moment, we tend to consider it as both a pro and an anti-inflammatory cytokine. It is responsible for induction of acute phase proteins such as C-reactive protein. We all know the importance of C-reactive protein. It also mediates prostaglandin E2 production, and it has a very important role in the switchover from innate to adaptive immune responses. Also helps in the differentiation and proliferation of B cells and induction of osteoclast formation, and also an important stimulator of MMP expression. Interleukin-8 is a chemokine, and it is very important with respect to neutrophil recruitment, and it has also been found to be inducing neutrophil chemotaxis, exocytosis, and also in the respiratory burst. Interleukin-17 is considered to be a pro-inflammatory cytokine, again helps in the recruitment of neutrophils and production of other pro-inflammatory cytokines. Now, maybe you have a fair idea that these cytokines actually don't function linearly. They have an intricate network. This is very important for us to understand, because we cannot really depend upon one or two of these inflammatory mediators to be creating the particular destructive process in any of these inflammatory diseases. So interleukin-17 has got the role of having a role in the production of other pro-inflammatory cytokines. Interleukin-23 induces interleukin-17 production. So you see the intricacy between the networking in these cytokines. You need interleukin-17, which helps in the production of other pro-inflammatory cytokines. But at the same time, you will be needing interleukin-23, which will be inducing the production of interleukin-17 itself. And of course, interleukin-23 also has got a role in neutrophil recruitment. Interferon gamma, this is a cytokine secreted by T helper cells type 1, and it is important with respect to macrophage activation and production of other pro-inflammatory mediators, one example being TNF alpha. And TNF alpha is a pro-inflammatory cytokine. It is again going to be very, very important with respect to other cytokine release. For example, just trying to limit to the number of cytokines we are going through today, it will be having a role with respect to bringing about an increase in the cytokine release, especially with respect to interleukin-1 beta. It also has a role with respect to chemokine release, cell differentiation, and inhibition of apoptosis, activation of the cyclooxygenase pathway, and production of C-reactive proteins. So, as Prisha et al. In 2013 stated, it is becoming increasingly clear that cytokines interact and function in networks, but we do not fully understand the complexity of these networks. So from a diagrammatic representation point of view, this is how the cytokine network will look like. And if you can probably remember, when a lot of research and studies were being done with respect to the COVID-19, they came up with this particular explanation that there is something called as a cytokine storm. The cytokine storm results in a lot of destruction because of the inflammatory process. So COVID-19 to a certain extent is considered to be a cytokine storm. So probably from the point of view of perio and diabetes, there is a mini cytokine storm, and it is very difficult from a generalization point of view as to which cytokine is important in bringing about these particular destructive changes. But however, at the moment, I would recommend that you have a picture that cytokines work in networks, and this is how the networks would look like. Apart from cytokines, we have certain other mediators, and these mediators I'm introducing for the simple reason that they are important from the point of view of diabetes. The most important of these are the adipokines, out of which the first one is leptin, which is synthesized by the adipose tissue, and its circulating levels actually reflect body fat mass. It has a thought role with respect to inhibition of insulin secretion as well as action. It activates the inflammatory response by acting on the acute phase, by acting as an acute phase reactant and a stimulator of neutrophil chemotaxis, and also has an influence on cell-mediated immunity. We need to also remember that leptin can mediate pro-inflammatory responses by stimulating cytokine secretion by other cells such as monocytes. The next adipokine is adiponectin. Now, adiponectin is considered anti-inflammatory. So it basically has been found to be associated with control of insulin action, and it can also exert an inhibitory effect on pro-inflammatory cytokines. So we have this particular anti-inflammatory mediator, which may be bringing about a balance by lessening the levels of pro-inflammatory cytokines. And as a matter of fact, this adiponectin can actually bring about an increase in the release of interleukin 10. And interleukin 10 is considered to be an anti-inflammatory cytokine, which has got a recognized role in the pathogenesis of periodontitis. So apart from this, adiponectin can also be having an effect by inhibiting TNF-alpha. The next adipokine is resistin. This is supposedly having a pro-inflammatory role, and the explanation is that it upregulates nuclear factor kappa B, TNF-alpha, as well as interleukin 6 secretion, as well as interleukin 12 secretion. As a matter of interest, I'm putting forward this particular paper, which was worked upon by my colleagues and myself. This happened way back in 2013, wherein resistin was still not really evaluated with respect to periodontitis and diabetes. And we actually found that resistin levels are much higher with respect to its values in the gingival crevicular fluid. So this is one particular aspect which brings about the fact that diabetes may actually be having a role to play by the so-called local dumping, thus accentuating some of the pro-inflammatory mediators in local sources such as the GCF and the saliva. Another adipokine is VISFATIN. This is an insulin mimetic mediator, and its expression usually increases during obesity. TNF-alpha and interleukin 6 are supposed to enhance VISFATIN synthesis, and interleukin 6 negatively regulates VISFATIN mRNA in adipocytes, although it may be having an opposing effect. Now, we need to understand that all these mediators will probably be having contradictory effects, but by and large, we are depending upon the majority of the studies which attribute to these particular mediators an assigned function. So we shall be taking it across from that point of view, for the simple reason that you have hundreds of articles, research articles, which have been published, and you're bound to find a few articles which will be contradicting the generally accepted role for the behavior of these particular mediators. Apart from adipokines, we have C-reactive protein, and C-reactive protein from a periodontal point of view is very important because we have also have it as a grade modifier in our latest classification of periodontal diseases, and it is considered one of the most reliable systemic markers of inflammation. And just when I was mentioning about interleukin 6 in the beginning, C-reactive protein is regulated primarily by interleukin 6 levels, and it has been found to be elevated in both obesity as well as diabetes. And C-reactive protein enhances the pro-inflammatory activity of other inflammatory mediators. Other than this, we have the AGEs. From a periodontal point of view, we know that the AGEs are pretty much important from the point of view that diabetes basically drives the production of excessive AGEs, because AGEs are generally produced even in normal homeostasis. But when there is a diabetic state, there is going to be an increased in the amount or the quantity of AGEs. And this basically results in a lot of pro-inflammatory behavior, including the possibility of AGEs bringing about an increase in the secretion or expression of pro-inflammatory cytokines such as interleukin-1 beta. So AGEs are also pretty much important from the immunological aspects of diabetes having its effect on periodontal diseases. Of course, RANKL and osteoprotegerin. We know that if RANKL is upregulated and osteoprotegerin is downregulated, then we do tend to be having more of a bone loss. So we have in the literature reports which state that whenever there is an increased RANKL and osteoprotegerin ratio, there is going to be more bone loss, especially with respect to individuals afflicted both with diabetes as well as periodontitis. Another important player nowadays is mitochondrial dysfunction. We know that mitochondria are the main intracellular source and the immediate target of reactive oxygen species. And approximately 1 to 5% of the oxygen consumed by the mitochondria is converted to reactive oxygen species under normal physiological conditions. But it is during an abnormal condition that the reactive oxygen species start increasing, and we know that reactive oxygen species have a devastating role to play with respect to the destruction of periodontal tissues. So in diabetes, for that matter, mitochondria, when exposed to high concentrations of glucose, which in other words means to say in a state of hyperglycemia, there can be more oxygen use and higher redox potential, which brings about an increase in the formation of reactive oxygen species. So taking all this into consideration, reactive oxygen species, because of oxidative stress in diabetes, will be a major player in the pathology of microvascular complications. And the unifying pathological condition, underlying pathological condition causing diabetic complications is an overproduction of superoxide by the mitochondrial electron transport chain. Now, the overproduction of these ROS has been noted in periodontitis, and oxidative stress enhances alveolar bone loss in periodontitis that occurs in people with diabetes. So we have basically an emphasis of all these inflammatory mediators in a condition where a particular individual has got both diabetes as well as periodontitis. Now I take you back to the same cytokine network, but having come thus far, we will have to remember that apart from just this, we can also have, with respect to specifically diabetes, the role of AGEs, reactive oxygen species, CRP, adiponectin, leptin, resistin, VISFATIN, and of course neutrophil defects. To cap up neutrophil defects, it is actually a paradox with respect to inflammation, especially in relation to diabetes and periodontitis when it is occurring together. Ideally speaking, in an inflammatory condition, you would be requiring the neutrophils to be recruited, which actually does happen. But at the same time, for explanations not really clear, these neutrophils have defects which result in reduced chemotaxis as well as their phagocytic ability. And at the same time, we need to know that neutrophils also undergo apoptosis. And this apoptosis, as described, is programmed cell death. Now, this particular apoptosis basically happens because we do not require a particular cell for a very, very long time because it sort of disrupts the balance. So, however, whenever there is a particular insult, say from the point of view of any bacterial virulence, these neutrophils will be delaying their apoptosis so that they can exert their particular phagocytic activity. But with respect to diabetes and periodontitis, this particular apoptosis happens earlier. So the particular individual will not be able to mount the required immunological reaction to curtail the particular infection. So all these have an intricate mechanism and a very complex role to play with respect to both diabetes and periodontitis. So from the point of view of the oral or periodontal immunological aspects in diabetes, I would say that this is probably the most simplified way of looking at it. You have cytokines playing a central and pivotal role. And in addition to that, because of the existing diabetic condition, you have all these other factors which will be having a role to play. So I'll just take you quickly through some of the well-known mediators just in periodontitis as a standalone local inflammatory condition. So I've already mentioned this, that pro-inflammatory cytokines are of central importance in periodontal disease. And there is a substantial change in the immunological active molecules as a result of diabetes that might perturb the finely balanced cytokine network. This is very important. We require to have a very fine balance with respect to the cytokine network. Now, if this particular network is disturbed, then there is going to be a prolonged or protracted infectious or inflammatory condition. Now, cytokines also link the innate and adaptive immune responses regulated by the T cells. And of this, interleukin 12, interleukin 18, and interferon gamma have important roles in the bridging of the innate and the adaptive immune responses, especially in periodontitis. A local overproduction of interleukin 1 beta and TNF alpha by the innate host defenses is a major contributor to alveolar bone destruction. Interleukin 6 promotes bone resorption both alone and synergistically with interleukin 1 beta. These are some of the important points I'm putting across so that there is a better understanding of the molecular basis of the pathogenesis in these two conditions. Getting back to local dumping, with respect to the influence of diabetes on periodontitis, the increased systemic levels of pro-inflammatory cytokines will influence the local conditions. That's the reason I am referring to it as local dumping. Again, taking into account the evidence as to whether it is actually true, that is, whether there is so-called local dumping, the levels of interleukin 6, the levels of interleukin 1 beta have been found to be increased in GCF. And also, when there has been comparative assessments between groups of patients with poor glycemic control and better glycemic control, it's been found that the GCF levels of interleukin 1 beta is usually higher with respect to people with poor glycemic control. Apart from this, there is also higher prostaglandin E2 and interleukin-1 beta levels when patients with diabetes are compared with non-diabetic patients. There is persistent TNF-alpha expression in the diabetic state and is associated with prolonged inflammation in response to periodontitis. There's also been higher levels of interleukin-17 and lower levels of interleukin-4. Interleukin-4 is also at times considered an anti-inflammatory cytokine. So in patients with diabetes and periodontitis, when compared with systemically healthy patients with periodontitis, we find higher levels of interleukin-17 and lower levels of interleukin-4. The other aspect with respect to, apart from cytokines, is leptin being present in the gingiva in concentrations that are inversely correlated with increasing probing depth, meaning to say that even a dysregulation in the leptin profile has been found with respect to people having periodontitis influenced by diabetes. Now, the RAGE present on the surface of mononuclear cells may interact with the AGs. We know that, especially in the gingival tissues, resulting in a state of enhanced oxidative stress. This results in upregulated cytokine secretion and the generation of ROS, this bringing about an increased local tissue damage. So this can, to a certain extent, account for the elevated concentrations of inflammatory cytokines such as interleukin-1 beta in the GCF, which I had just mentioned slightly earlier. So we have, under the circumstances, what we refer to as the diabetic hyperresponder, which has appeared in the literature, wherein this diabetic hyperresponder actually mounts an upregulated immune inflammatory response in the periodontal tissue, leading to an increased tissue destruction. So the bridge, I was talking about the inflammatory bridge in the beginning. So from the point of view of considering both, interleukin-1 beta levels are elevated in inflamed periodontal tissues. Hyperglycemia induces interleukin-1 beta production, which impairs their function. Interleukin-6 in periodontitis and diabetes acts as both a pro-inflammatory or an anti-inflammatory cytokine. This is what I mentioned earlier, that interleukin-6 can at times be considered a joker because you really do not know what interleukin-6 actually does and under what exact conditions. Interleukin-4 and 10 are usually anti-inflammatory, but at the same time, they are also considered as multifunctional cytokines. TNF-alpha, without any doubt, is usually higher in diabetes, and it has also been suggested that TNF-alpha inhibits insulin activity. And persistent TNF-alpha expression in hyperglycemia presents a long period of inflammation in response to periodontal disease activity. We know that from one point of view, that chronic inflammation is nothing but frustrated repair. So you do have the particular insult still persisting, and yet repair is not happening on time. So chronic inflammation is basically frustrated repair. So that makes it very difficult from the point of view of a prolonged insult, especially when a periodontitis patient is having diabetes. So apart from these important cytokines and mediators, which have a very important role in the immunological aspects of periodontitis, other mediators may have also a role both from a qualitative as well as a quantitative point of view. So it may not be always conclusive that if you find a particular mediator in higher or lower levels, that it does not have a role to play, because there could be certain other qualitative aspects which still are to be understood. That makes it very challenging and very difficult to understand. So this is a particular picture which actually shows how the local tissues or the periodontal tissues will be when the particular patient is also having diabetes. Now, if you look at all the ones marked in red, there is an accentuation with respect to these immunological mediators in periodontitis in a person having diabetes, a generalized picture, wherein you will be having an increase in the TNF alpha concentrations, the interleukin 1 beta concentrations, usually the interleukin 6 concentrations. Apart from that, MCP1 as well as MIP1 alpha. At the same time, down here, you can see that there is an increase in the ratio of RANKL to OPG, thus bringing about more bone destruction. And right on top, if you see here, interleukin 4 is reduced. We already have come across interleukin 4 as an anti-inflammatory cytokine. So this basically gives you a rough idea as to how the immune mechanisms and the mediators are affected in periodontitis with a particular person having diabetes, wherein in addition to that, you have the reactive oxygen species which are increased based upon the fact that there is an increase in the production of the AGE in a diabetic individual. So this more or less captures the immunological aspects in a very simplistic way with respect to periodontitis in individuals having diabetes. If you look at another particular figure, cytokines and leptins as well as adiponectin. These are going to be having a role with respect to bringing about an increased insulin resistance, that is leptin and cytokines, and an inappropriate immune inflammatory response. We've already come across that adiponectin is usually anti-inflammatory, so they can actually bring about an inhibition of the insulin resistance. So this particular central core of adipokines as well as cytokines will be having a central role in both diabetes as well as periodontal disease. And we know from both sides that there are environmental factors. For example, in periodontitis, smoking as well as the quality of the subgingival microflora will be having its own effects. So all these with the underlying host susceptibility based upon the genetic factors will be bringing about a very important two-way street between periodontitis as well as diabetes. What is the clinical implication? One, pertaining purely to the immunological aspects is cytokine therapy. Now, cytokine therapy has taken an upswing with respect to diabetes research, but at the same time, cytokine therapy is also being explored from a periodontal point of view. So it is basically targeted molecular therapy. So this could probably be one of the important aspects with respect to the clinical implications pertaining purely to the immunological aspects of periodontitis as well as diabetes. But however, most recently in 2020, these were some of the articles which came across addressing diabetes as a risk factor for periodontal disease and the effects of periodontal disease on glycemic control, etc. And their most important conclusions are this: clinicians should be aware of the two-street mechanism between these two diseases. Diabetologists and physicians should seek evidence for the presence of periodontitis in patients with diabetes, ask about their signs, symptoms with respect to the condition of the periodontium. And oral care providers, that is us, we should perform a periodontal examination in each newly diagnosed case of diabetes, and an annual periodontal evaluation should be recommended for any patient of any age with diabetes. The clinically important facts about the association of diabetes and periodontitis include, as has already been so nicely presented by Dr. Prasanna Kumar earlier. So type 1, type 2, as well as GDM should be taken into consideration. Diabetes increases the risk of tooth loss. We should know that and make sure that we take the right preventive aspects as soon as we recognize the particular diabetic condition. There is also a very important need for appropriate control of blood sugar as well as weight, which has also been discussed earlier. So ultimately, whether it is immunological or clinical, the implication is that there should be a very, very important recognition of the role both diabetes and periodontitis have on each other. So that leads me to conclude with respect to this particular topic, that is the immunological aspects. The current concepts indicate that the following points pertaining to immunological aspects influence the two-way relationship between diabetes and periodontitis. Number one, dysregulation of pro-inflammatory cytokines and mediators. Number two, neutrophil defects. Number three, the effect of AGEs. Number four, an altered RANKL osteoprotegerin ratio. Number five, an increased production of reactive oxygen species. These were the immunological aspects which we actually dealt with in the entire presentation, which is very important for us to consider. Presentation has basically been an overview because there is enough and more data which is at times humanly impossible to fathom. But however, we also need to consider that individuals with poor glycemic control are at increased risk for periodontitis, and there is a shared cross-susceptibility between these two diseases because inflammation is the common pathway. Research has provided evidence that this disrupted level of cytokines and other mediators in periodontal tissues and in the GCF is usually more in patients with diabetes and periodontitis as compared to systemically healthy patients. So this plays an important role in the oral immunological aspects, resulting in prolonged inflammation in diabetes. So these are few of the selected references. And thank you very much for having me. So I leave you with, it's all about the network. Thank you so much.
Thank you, sir, for providing us an insight on the diabetes and periodontitis. As a dentist, it is very important for us to know the interrelationship between diabetes and periodontitis. And it has been rightly said that the best and the most efficient pharmacy is within your own system, and that is immunity. Over to you, panelists, Dr. Deepika ma'am and Sunil sir.
Hello, Dr. Anirudh.
Dr. Deepika, so nice to see you.
Yeah, nice to see you. I was very happy. This is a very, very good presentation. Very comprehensive too. And of course, we don't expect any less from Anirudh. We've known you for so long, and you've been our colleague. It was a very comprehensive presentation of a complicated topic. You know, there is a cytokine storm in my head now. It needs some time to calm down. So I would like to, without much ado, I would like to invite questions from the audience. I think I already see something here. I'll just have a look. What is the role of monocyte and macrophage signaling in periodontitis with and without type 2 diabetes mellitus?
Okay, basically the answer has been sort of provided maybe subtly in the entire presentation. Now both the macrophages and monocytes will be triggered into activity by the cytokines. Now, when there is a disruption with respect to any of these cytokines, there is going to be a direct impact on the qualitative role or the functional role of these macrophages and monocytes. So whenever you have a depressed activity of these defense cells, to a certain extent, I think I gave a slightly prolonged explanation regarding neutrophils. There is going to be a decrease in the mounting of the attack against the bacterial invasion by both the monocytes and the macrophages, which results in depression of the functional aspects of these cells as well as an increased inflammatory process.
Any other questions? Only Dr. Asha Srinivasan's question has been answered. Any questions from the audience? Any more? I think I have one more here. Just have a look. No, that's it, I think.
I think it's
I have one.
probably...
Can I just barge in? Do you have the time, Dr. Acharya?
Yes, please.
Nothing. Is there a pathway that we can put across, like the ages? Just the adipose, the fat pathway for our.
You're talking about the accentuation of periodontitis in diabetic individuals with a singular pathway?
Yeah.
Yes, you can put a singular pathway, but you need to take into consideration that that is not the only one. So you can probably give a main column, but at the same time keep adding, the other factors which come into play. So I would probably not really prescribe to the fact that there could be one particular pathway, because every now and then, now even if you looked at the literature, probably 15 to 20 years back, there used to be a lot of research with respect to single mediators. But of late, it has been realized that we really cannot depend upon one particular mediator or two particular mediators and then build up on a pathway. So that is the reason why more and more research is focusing on multiple mediators, so that we can actually come up with, as you are suggesting, a particular single pathway. But the single pathway is not going to be linear. That is what I was mentioning earlier also. We cannot probably depend upon it being a linear pathway.
So you suggest that we put in all these inflammatory markers and have an overall picture?
Yes, if you have the means to do it, that will be perfect. I mean, anybody for that matter. But by and large, it becomes very difficult everywhere. Yeah.
Yeah.
And to a certain extent, since you brought up this, I can also probably mention to you that even if you come up with a particular pathway, it may not hold water in all ethnicities, for the simple reason that I can probably draw your attention to one particular study which was done in Sweden, wherein they found that Swedish people, as compared to Swedish citizens of Iraqi origin, had different profiles with insulin resistance, as well as the expressions of different inflammatory mediators. So even if we do develop a single pathway, it may probably be difficult to give a very generalized explanation pertaining to every race or ethnicity. So that also has to be taken into consideration. And I think, as Dr. Prasanna Kumar earlier in his presentation put it across, genetic factors as well as race and ethnicity are some of the factors which need to be considered in this very, very challenging topic. And that is probably the reason why there is incessant research which is going on to try and find the answers. So I would put it that way.
A few more questions are there. I'll just read out. Dr. Asha again. Talk was more on adaptive immune system, but what cells are APCs from innate immunity?
What cells are?
APCs from innate immunity. Probably some grammatical. Or we can move on to the next question.
Yeah.
If one's mitochondria is damaged due to ROS, is there a recovery of mitochondria, and how about its role in neurons?
Now mitochondrial defects are something which are yet to be explored comprehensively in perio. So I don't think I can give a very clear answer to that. But one of the aspects which has been found is that, because we first had to find out whether that particular person is, first of all, having a mitochondrial defect. Now, unless and until we are sure about whether that person is having a mitochondrial defect, it would probably be not so, pragmatic for us to actually say that, this is purely because of a mitochondrial defect. Unless and until we know that the particular person is having a mitochondrial defect, we cannot really say that. And if mitochondria is damaged due to ROS in a recovery of mitochondria, how about its role in neurons? Would the question be having any implication with respect to diabetes from the point of view of we taking into consideration perio? I would ask that. In neurons, if you're looking at it from the point of view of neuropathies, etc., yes, maybe. But from the point of perio, I don't see anything there.
I'll see if there are any questions. One more is there. Is there a cross between JMJD3 and monocyte or macrophages?
One second.
Shall I repeat?
Yes, yes. Is there a cross between?
Cross between JMJD3 and monocyte bar macrophages.
No.
Madam,
not
good
at all.
afternoon. Can I talk? Sorry.
Yes, please do. Please do. Yeah.
Sorry, sir. This is Asha.
Yeah. Hi, Asha. How are you?
Hi. It was a fantastic talk. I thoroughly enjoyed it. So
Thank
my
you.
first question was, there was more about adaptive immune system. So I was
Yes.
wondering which are the antigen presenting cells from the innate immunity which will actually activate this adaptive immune system. Because there need to be a role of antigen presenting cells to bring that cytokine storm in periodontitis.
No. Please don't get me wrong here. It was just a suggestion. I am not mentioning that there is even a mini cytokine storm. I was just trying to bring an analogy. So
Okay.
please do not mention cytokine storm in periodontitis, because I have had discussions with experts and there have been reasons for them to say that we do not have enough and more cytokines to actually qualify periodontitis as having a cytokine storm.
Okay.
That's the reason I used mini, and it is purely off literature. It is just to bring to you a particular concept that yes, it is basically because of the interaction of the cytokines that you do tend to have a prolonged inflammatory burden, especially when you have a comorbidity such as diabetes. So that was the point. I hope that is clear. So you really cannot take it into consideration that you can compare it to the cytokine storm of COVID. No.
Right. Okay. Then is there any crosstalk between JMJD3 and monocyte and macrophage?
Maybe.
Okay.
I cannot give you a conclusive answer, but yes, maybe. But I think there are only 1 or 2 reports regarding this, and I'm not
There
really
was one published in Nature, but
Yes.
yeah.
So again, I have not read that particular article in completeness. So though there is a crosstalk, how much can we actually depend upon it, and what would the clinical implications be for this? That remains to be answered. I mean, this is from a pure basic research point of view, yes. But at the same time, if you look at this with respect to its interaction, both with respect to the mediators as well as 2 conditions, inflammatory conditions like diabetes and periodontitis, may be difficult to answer.
Okay. Thank you very much.
You're most welcome. Thank you for the questions.
One last question, Anirudh, from Dr. Vinaya. Diabetes on growth factors and regeneration. Kindly throw details on it.
Diabetes on?
Effect of diabetes on growth factors and regeneration.
Well, if we are talking about uncontrolled diabetes and uncontrolled hyperglycemia, yes, we are not going to be having a great lot of regeneration. But however, with respect to controlled diabetes, there should be no difference with respect to the regeneration capability as well as the function of growth factors as compared to individuals who are not hyperglycemic. So we basically tend to look at, because from that point of view, most important aspect is it is very difficult for us to actually reverse diabetes. We can bring it under control. We can't bring it absolutely to normalcy. From that point of view, if you're looking at it from the clinical point of view, wherein you would want to do some regenerative procedures by probably introducing growth factors, yes, in a group of individuals who are having controlled diabetes, you can go ahead. It should not be having any different outcome as compared to people who are not diabetic.
Okay, thank you. And in the chat box, there is a compliment for you. Can you please provide the recording of the wonderful presentation? It will be of great help. Of course, we will be uploading it on YouTube, and everybody will get to watch it again at leisure, or sort of forward it to other interested parties as well. I'm very happy, Anirudh. You gave a very good talk, and of course, we expected this from you, and you've sort of lived up to our spoke up to our expectations. And I was wondering if Sunil has to add anything. My co-panelist Sunil Tejasvi, if you want to add anything here.
Yes, thank you for a very good talk, Anirudh. It was very informative.
Thank you, sir.
But
Thank you so much.
my doubts are a little bit different since I'm a endodontist. I was wondering if there is any relation between this mucormycosis and the immunological markers you were speaking. Is there any?
I
anything
am not.
which is
No,
related?
no. I probably cannot give a definitive answer on this, sir, because it will entirely depend upon the number of cases which have been implicated in this. We are not dealing with that right now. So, from an endodontic point of view,
Because a few days back, we just saw a case with mucor. It was like severe periodontitis was there. Oral health was excellent, but gross bone destruction and multiple mobility of the tooth in all the segments. Is it anywhere interconnected with this cytokine thing which you are speaking? I just wanted to know.
so the possibility, if we can give an umbrella answer, then yes, there is going to be a dysregulation of cytokines in almost any inflammatory related condition. So from that point of view, yes. But the reason I'm saying that I will not be able to answer it is because I do not have literature to back me up. I can probably give you an anecdotal thing for the simple reason that we also came across just one case, of severe, but we couldn't attribute it because it's just a case. We couldn't really attribute it to what kind of an implication it has with the cytokine. So I really won't be able to give you solid answers. Anecdotally, yes, you are right. There could definitely be a connection.
So I agree with you. Actually, any infection for that matter would trigger an inflammatory response. So considering that there are some rare cases of mucormycosis which are slightly increasing in number, there could be some element of what Dr. Sunil Tejasvi is talking about.
Yes.
There could be some this thing. But right now, since in infancy, the research aspect of it, where they are exploring probably at various avenues to look out for the inflammatory areas. As any infectious disease, there would be a hike in the inflammatory mediators or the markers. Yes, of course, we've had cases in JSS hospital, 2 or 3 cases of that, but we have not explored any inflammatory pathway or a detailing of that aspect. And I think Dr. Sunil has a positive point regarding that. Maybe we need to explore on that.
Yeah, thank you very much. Thank you.
And as mentioned, because this particular field of immunological aspects is so vast. Now, if a particular point is made that TNF alpha is increased, there could be a counterpoint saying that no, in that same situation, TNF alpha has been decreased. So it becomes very challenging for us to actually give very conclusive evidences pertaining to this particular thing, because as I mentioned earlier, if there could actually be a difference in the cytokine behavior or immunological behavior from different races and ethnicities, even if we are looking at most of the studies which have been done in Caucasian populations and a few comparisons here and there, it becomes very difficult for us to actually come to a conclusion. So there are probably about more than 600 articles pertaining to this particular field, only diabetes and periodontitis, and thousands with respect to just immunological aspects. So you put forward one concept, there could be a contract with respect to that. So that makes it quite challenging, and it's going to go on and on, I think, for quite some time.
So if there are no more questions, can we conclude the session? Sunil?
Sorry, madam.
Okay, thank you once again, Anirudh. We do conclude this session. Thank you very much.
Thank you so much for having me.
Thank you.
Thank you, Deepika ma'am. Thank you, Sunil sir. I request Dr. Anirudh sir to kindly accept the certificate as a token of appreciation.
Thank you so much. And my compliments to the organizers and to JSS.
Thank you, sir. I request Dr. Deepika ma'am and Dr. Sunil sir to accept the certificates as a token of appreciation. We are done with our day one programs of this webinar series. I request you all to kindly join us tomorrow at 10 a.m. for the upcoming sessions. Thank you.
Thank you.